All right. My clock tells me it's 2:15 and we're going to keep this ship right on time. Hi, everyone, and welcome. I'm John Horrigan with the All of Us Research Program. As we get started here today, I've got a couple of housekeeping items just to touch base with you on. So first, closed captions are available throughout the day. To turn on the captions, click the CC icon in the top right of your screen and choose your preferred language. To ask a question, select the Q&A option at the top right, type in your question, click submit. And just so you know, the QA is private, but it's monitored by all of us staff, so we'll see that on our side. Questions submitted through the chat box won't be monitored. The chat is public, so others will see that. So just be mindful of any personal information you might share there and where you put your questions, just to be sure we get them. This research panel 3 is going to focus on how life circumstances shape health. I am very excited to have the privilege of introducing to you our 3 panelists. They are Eric Kim, who is a predoctoral graduate student at the University of Illinois, Chicago, Brian Anderson, who's an assistant professor at the University of Pittsburgh, and Yuan Liu, who is a senior software engineer at Yale University. Throughout the presentations, if you have any questions, again, put them in the Q&A section. We'll keep an eye on those, and we'll get to all of those at the end. We'll reserve about 13 minutes. Eric, Brian, and Yuan, I'm going to do my best to keep us on track with a timer over here, and I will do my best NPR interruption at the 10-minute mark if we need to get things going along. So with that, I'm going to turn it over to Eric Kim.
Hello, everyone. My name is Eric Kim from University of Illinois, Chicago, and today I'll present our work on improving lung cancer risk prediction using machine learning and All of Us data. Next, please. So lung cancer is still the leading cause of cancer death in the United States, and current screening guidelines focus mostly on age and smoking. But we thought that doesn't fully capture who is at risk. Next, please. So our goal was to improve lung cancer risk prediction by incorporating not just traditional risk factors like age and smoking, but also psychosocial and neighborhood level factors. And we also wanted to compare different machine learning approaches to see whether more flexible models improve performance. Next, please. So this is important because lung cancer risk and outcomes are not evenly distributed across populations. And there are known disparities by race, socioeconomic status, and access to care. But traditional models may miss these patterns because they don't account for broader context, like stress, social support, or neighborhood disadvantages. So our goal is to see how much these factors matter in capturing lung cancer. Next, please. And our data set had over 350,000 patients, and about 2,300 had lung cancer cases. Next, please. And we included predictors from demographics, smoking behavior, psychosocial factors like perceived stress and social support, and neighborhood context using the area deprivation index. This allows us to move beyond purely clinical predictors and capture more real-world risk factors. Next, please. So to do this, first we compared 3 models, logistic regression, random forest, and XGBoost. And we evaluated performance using both ROC AUC and PRAUC. And because lung cancer is rare in this data set, we used imbalance-aware strategies like class weighting and threshold tuning. Next, please. So here is the result of 3 different models. Because lung cancer is a rare outcome, we focus more on PRAUC, which is more informative than ROC AUC. And logistic regression and XGBoost had similar ROC AUC, but XGBoost model achieved the highest PRAUC of 2.34%, which is roughly 3 to 4 times higher than the baseline, which was 0.65%. And this indicates that the model is meaningfully better than random at identifying true cases under class imbalance. Next, please. And then we adjusted the threshold to prioritize recall. And at that level, we achieved about 84.5% sensitivity. Next, please. So now I'll briefly discuss model interpretation strategy. So we use SHAP values, which quantify the contribution of each feature to an individual prediction. However, because the dataset is highly imbalanced, feature importance can be biased toward non-cases. So to address this, we performed SHAP analysis on a balanced subset of the test data, which equal numbers of cases and controls. This approach allows for more reliable and interpretable identification of features associated with lung cancer risk. Next, please. And here is the result. So from the SHAP analysis, age and smoking remained the dominant predictors, consistent with existing knowledge we know. But importantly, we also observed that psychological factors and neighborhood deprivation contributed an additional signal. So as we can see, MOS score, and PSS score, and deprivation index showed high importance, similar to smoking factors. Actually, MOS score is even higher than the smoking factor. While these effects are smaller than age, they suggest that risk is influenced by broader social and environmental context, not just the individual behaviors. Next. And we also examined interactions between features. As you can see in this network plot, age emerged as a central driver with strong connection to smoking. And also social and neighborhood factors focused a strong cluster, indicating that contextual factors may modify baseline risk. This supports the idea that lung cancer risk is shaped by interacting systems rather than isolated variables. Next. And also, we evaluated model performance across subgroups. So we observed higher recall in older adults and ever smokers, which are traditionally high-risk groups. However, performance was really low in younger individuals and never smokers. This suggests that the model may be less sensitive in population, not well represented by traditional risk factors, and raising concerns about equity and generalizability. Next. And there are several important limitations to consider in this analysis. So first, lung cancer cases are relatively rare in this data set, resulting in class imbalance that may affect model stability and performance. Also, several psychosocial and neighborhood variables have substantial missingness. For example, approximately 91% of insurance type is missing, which may weaken the observed contribution of these features. And also, as this is an observational data set, the results reflect associations rather than causal relationships. Next, please. But these findings suggest that machine learning models can improve lung cancer risk stratification by incorporating broader risk factors beyond smoking and age. And this could help identify individuals who are currently missed by traditional screening criteria. However, our results also highlight that model performance is not uniform across populations. So to achieve equitable impact, future work should focus on improving data representation and ensuring models perform well across diverse groups. Next, please. And in conclusion, while age and smoking remain the dominant predictors, psychosocial and neighborhood factors provide an additional signal. Importantly, model performance varies across subgroups, indicating a need for more inclusive data and modeling strategies. Overall, this work highlights both the potential and the limitation of using machine learning for equitable risk predictions. Next. And finally, thank you And thank you to all of us participants and research team for making this work possible. Thank you.
Eric, and next up we have Brian.
Okay, hello everyone. I'm Brian Anderson from University of Pittsburgh, and on behalf of my collaborator Jacob McCary, I'll be discussing our study titled "Who Receives Low-Value Spine Care?" A cross-sectional study using All of Us data. So we know that low back pain is one of the most common reasons that people see a healthcare provider, but many of the tests and treatments that people receive don't actually provide much benefit and can actually cause harm. So using All of Us data, we asked a simple question: who is most likely to receive this kind of low-value spine care? So you can leave this slide on here. So we studied adults who had a new episode of low back pain in 2021. We excluded people with urgent problems like fractures, or infections. We followed these subjects for a year after their first visit, low back pain related visit, to see who received low value care, focusing on things like early imaging studies, injection procedures, opioid medications, and surgery. We looked at patient characteristics like age, race, income, education, and chronic health conditions, and used statistical models to see which ones mattered the most. Next slide, please. Next slide, please. Okay, keep going. Thank you. All right, so cohort inclusion. We identified nearly 27,000 adults with new onset low back pain in 2021. And of those, roughly 61% received none of the low value interventions that I previously mentioned. And when they did receive at least one of these interventions, imaging studies were by far the most common, and surgery was quite rare. So there's no single perfect way to define low value care. So we looked at it in two ways. Number one, a broader definition, and number two, a stricter definition. So the broader definition is labeled sensitive, and the more strict definition is labeled specific. So for example, early imaging counted as low value care if it happened within 6 weeks in the strict definition, or any time in the first year in the broader definition. So next slide, please. So for the sake of time, I will save any further discussion about these specific operational definitions for the Q&A, but this is a table describing how each of those were defined. So next slide. So this table summarizes the characteristics of our cohort, comparing participants who did versus did not have low value care exposures. So prior to any adjustment with statistical models, participants with low value care tended to be older, be white and non-Hispanic, and have more chronic health conditions. So there'll be a couple of clicks here, so my apologies for that. Go ahead. Yep. Thank you, and next slide. Perfect. Okay. So this figure is called a forest plot, and it provides a visual representation of the statistical models which accounted for individual characteristics. So I'll note that only statistically significant predictors are shown, and they're in the rows of this table, or this figure. So the red diamonds you see in the plot represent how strongly each characteristic is associated with the exposure being evaluated. And in this case, it's a composite measure, a composite outcome called any low value spine care, which is any of the 4 interventions that I previously mentioned. So for the broad definition, that's documented here. The red diamonds are all to the right of that dotted vertical line, meaning that they are linked to increased risk of low value care. So prior imaging studies and opioid medications were the strongest predictors, with 85% and 79% increase in low value care in the future for each prior exposure, respectively. Next slide, please. So here is again the forest plot under the stricter definition with the same outcome that any low value spine care composite measure. So the green diamonds associated with sociodemographic factors you can see are to the left of this dotted line, meaning these characteristics are associated with lower rates of low value care. So for example, Black participants had a 10% lower rate compared to white participants, and low income had an 8% lower rate versus moderate income, and Hispanic ethnicity showed a 13% lower rate versus non-Hispanic ethnicity. So these are populations we might expect to have equal or greater clinical need, yet they receive less care. Next slide, please. So if we look at the individual low-value interventions, imaging studies deserve special attention because it often starts a chain reaction of low-value care. So under the broader definition on the top half of the slide, younger adults had a 26% lower rate of imaging while having two or more chronic, or exactly two chronic conditions versus none, increased imaging rates by 75%. Prior injection and surgery were both strong risk factors for future imaging. And the major difference under the strict definition on the bottom half of the slide was that Black participants had a 17% lower rate of imaging versus white participants. Next slide, please. Similar results were found for injection procedures, with the strongest risk factor being prior imaging studies. So receiving an imaging study prior to the index visit led to future increased rates of injection procedures. And we also found, again, that a 29% lower rate of injections were identified among Black versus white participants under the strict operational definition on the bottom half of the page. And we will skip to the next slide. So here we're looking at opioid medications. And opioids showed the strongest influence of social factors because of the volume of opioids that were prescribed in our data set. So lower income and education were associated with lower opioid use, while unemployment and having multiple chronic conditions greatly increased opioid rates. So let's go to the next slide. And finally, we have surgery, and there were very few, relatively few surgical procedures documented in our data set. So the only significant predictor that we identified was previous imaging studies as a risk factor for future surgery. Okay, we can skip to the next slide. So to summarize, we conducted a cross-sectional study using electronic health records data and survey data to identify individual level predictors of 4 different types of low-value spine care among a large cohort of adults with new low back pain episodes. So our 2 key findings that emerged were, number 1, that prior imaging creates what is called a utilization loop. So once patients enter this loop, they're far more likely to receive additional low-value care in the future. And second, lower rates of low-value care among racial and ethnic minorities and lower income participants likely reflect access barriers and under-treatment rather than appropriate care. So addressing low-value care requires tackling both overuse and inequities at the same time. Next slide, please. There's my timer. And we just wanted to thank all of the All of Us research participants and program for their generosity and for allowing researchers like myself to access their data. Thank you very much.
All right. Thank you, Brian. You guys have been really great on time. I appreciate that. Managing it yourselves. We're on to Yuen next.
Thank you, John. Hello, everyone. This is Yuen. It's my great pleasure to share our study about the relationship between prescription for controlled substances and opioid use disorder. So in this study, we use all of us data to look at how prescription patterns, social factors, and genetic risk are related to opioid use disorder risk. Next, please. So I will briefly introduce the study, show the cohort and key results, and then end with limitations and our next steps. Next, please. So the opioid misuse and sedative misuse are still major public health problems. What makes our study more meaningful is that all of us lets us connect EHR prescriptions, diagnosis, as well as survey data, also the genetics in just one research environment. So the All of Us research workbench really helped at the beginning of this project because it made it possible to build just one multimodal data set instead of working with separate data resources. Next, please. So in simple terms, we asked one question. After a person gets an outpatient opioid prescription, how long does it take before the opioid use disorder happens, and what factors are linked to that risk? So we found that risk is not explained by opioid dose alone. It is also shaped by multi-factors together, including like the prescribing patterns, the benzoyl use, social determinants of health, as well as the polygenic risk score. Next, please. So before I go into methods, I want to acknowledge that this work depends on the generosity of all of us participants and the research community. Without them, this study would not be possible. Next, please. So next, I will show how I built the study cohort. Next, please. So this slide shows our full study design. The main question is how long it takes to develop opioid use disorder after the first outpatient opioid prescription, and which prescription, social, clinical, and genetic factors are associated with that risk. So here, I use the EHR prescription data diagnosis as well as the survey data and the genomics data as well. Opioid use disorder was defined using the ICD-9 and ICD-10 codes. Remission codes were excluded here. And the event only counted if like the first opioid use disorder diagnosis happened on or after the opioid initiation. Next, please. So here we created 4 cohorts under the same shared restrictions: outpatient medication records only, and a pre-cancer window to remove the impact of surgery and cancer opioids using. So from the All of Us background cohort, we created a target opioid cohort, a benzo Z-drug covariant cohort, and the lipids diabetes comparator cohort. Next. So this slide shows the filtering inside our target opioid cohort. Next, please. So this timeline shows how follow-up was defined here. The index date is the first outpatient opioid prescription start date, and we started from people with at least one computable baseline MME field after requiring at least 1 year of clean look-back period, at least 180 days of follow-up window, and also the PRS. Next, please. We can jump this. So from this demographic table, our table 1, we can confirm that our study cohort are broadly similar in basic demographics. So later comparisons are more meaningful. From this table 1, we can see that the key difference is outcome, like the opioid use disorder after first opioid exposure is clearly more common in our target opioid cohort than in the comparator cohort. Next, please. So this table focuses on selected social determinants of health questions. I don't have time to read through every cells here, but like the main point is that income, neighborhood trust, education, and related social measures were available for analysis. And some of these later showed very meaningful association with the opioid use disorder risk in the adjusted model. Next, please. So next, I'd like to explain how I standardized the drug exposure. Next, please. So here we know that the MME and DME allow us to compare different drugs on a common daily dose scale. So this is better than using simple like the prescription counts, because counts do not capture dose strength, duration, or exposure intensity. Next, please. Next, please. Yeah. So this slide shows the processing pipeline for daily opioids intake. So we began with 762K opioid fills. After duration quality control, the MME computation, and then the sensory rules, we retrained like the 19K people with at least one computable MME fill for the survival-related analysis. So the important message here is that the dose was not guessed loosely. It was carefully standardized and quality controlled before modeling. Next, please. So this figure shows the opioid trend over time. The percentage of individuals in the trend set peaked in 2015, but the highest mean MME per day happened later in 2023. So as we can see here, although the proportion of people is going down in recent years, the average opioid dose boundary is not going down in the same way. Next, please. So we see a very similar pattern for benzos and Z drugs. So the yearly proportion of benzos Z drug users peaked in 2015, but like the later highest mean DME per day was in 2023. So again, like fewer people does not necessarily mean lower intensity among those like who are still exposed. Next, please. So now I will move to the survival question. How long does it take to develop opioid use disorder, and what factors matter most? Next, please. In our survival cohort, 7,387 participants meet both the 1-year clean look-back period and the 180 days follow-up window requirements. So the median time to opioid use disorder was about like 4.2 years. And we can see that this is not only an immediate short-term risk issue, it extends like across years after the first opioid prescription. Next, please. So this is the main finding slide. The model performed well with a Cox index of 0.8 and a binary AUC of 0.8. So the strongest higher risk factors were polygenic risk score, first opioid MME per day, year of like the first opioid prescription, and sex at birth. So we can also see that factors associated with lower adjusted hazard include higher household income, better neighborhood trust, as well as the higher education level. So the main message here is that the opioid use disorder risk is multifactorial. So it reflects clinical exposure, social context, and the genetic risk together. Next, please. So our study may help support earlier follow-up, better counseling, and safer prescription. So I also want to highlight that the All of Us research workbench helped us bring together both EHR data and survey data as well as the genetic data in just one place, which made this study possible. Next, please. So here I'd like to talk about the main limitations of our study. So we are missing some survey data and the fact that the PRS performance may not transfer equally well across ancestry groups in a diverse cohort. So our next step are to improve the social determinants of health handling, reduce the dependence on self-report alone, and evaluate PRS performance more carefully by ancestry. Next, please. So I would like to thank my collaborators at Yale, USA, and University of Washington for their support and feedback on this work. The manuscript is currently in preparation, and we are continuing to improve the analysis. Thank you.
Great. Thank you, Yuan. We have, we're like a full minute ahead. This is great. Thank you, guys. We'll bring everybody back on stage here on the screen so Eric, Brian, and Yuan can join me here. And we'll start to get into some of the questions that we got during the talks. I'm going to kick things off with sort of a general question. I'm going to get to the specific ones here in the chat. But Yuan, you alluded to this, that the All of Us data set was sort of appealing for this project because it was a rare place where you had EHR survey and genomic data all in one place. So Eric and Brian and Yuan, to you as well, I'm curious, what were the advantages of this data set over other methodologies, right? You could do potentially chart reviews within institutions. You could do other approaches to this. So I'm just curious how the use of this data set, the availability of the data from All of Us maybe helped out or was an advantage, or how it works relative to other options.
I'm happy to answer that question real quick. So until I started working with All of Us data, the majority of my research was using administrative claims data, so health insurance claims, and even very large data sets like Medicare data and private insurance claims data. There's the limitations are that you don't have any kind of clinical context for what you're evaluating, right? It's diagnosis codes and procedure codes, and you might get some demographic variables as well, right? So the advantage of the All of Us data set, which you've already mentioned, is not only do you get those variables, but you get all of the survey data, and it's just a rich combination of healthcare related data that you can use and combine in different ways that gives you a kind of a bigger or more rich picture of answering your research questions. So very appealing for me.
Great. Eric, there's a couple of questions for you here, so I'm going to start with these if that's okay. The first question here was what it was for you specifically. Is the ADI already computed in the database, or did you have to compute that yourself using a publicly available source or some other sources? And there's a second question that you can see. We'll get to that one momentarily.
Okay, so ADI variable, it was actually in the AOU, like All of Us dataset environment. So I think it was from zip code level. Like there is a 3-digit zip code level, and you can get it from there. Yeah.
Fantastic. Great. The other question for you, Eric, while we're chatting, I'll throw this out there, and then Brian, I've got a question for you and for Yuan, so I'll give you both a little bit of time to review those in the chat. But Eric, the other question that came up was, what's the advantage of one versus the other, the PR AUC versus the ROC AUC?
So PR AUC is more informative than ROC AUC here because lung cancer is rare outcome in our cohort. Like only 0.65% of lung cancer outcomes there. And ROC AUC can still look reasonable even when a model produces many false positives in highly imbalanced data, where PR AUC focuses directly on precision and recall. So it's actually better reflects how well the model identifies true cases without being dominated by the other large number of like non-cases. So that is why we emphasize PR-based evaluation alongside like the ROC AUC in the
rare outcomes.
Thank you, Eric. Brian, I'm going to come back to you on this one, and then Ewan, giving you another second to take a look at a couple of questions for you. Brian, we had, I think your presentation struck a nerve with people, and I say that like in the worst of dad jokes, thinking of back pain and nerves and all that. But folks were sort of curious about what your research can tell us about, let's say, access to care and sort of the low value care that is oftentimes the first step, and sort of what's out there in terms of treatment related pain, in particular treatment related options that are being studied, and how sort of that intersection.
Yes. So what I presented today was a small piece of a larger research project, and an important component that I didn't discuss today is the impact of not only the initial provider that someone sees for a new episode of low back pain, but the trajectory of care that they receive in the early phases of low back pain, right? So most of my research prior to this has been evaluating that variable specifically. Is how does future healthcare utilization, how is it impacted by care patterns received in the early phases? And in general, if you go to a provider that is kind of has a more kind of drug related approach, that's probably what you're going to receive. And overwhelmingly, we see that patients who seek care for back pain in the emergency department are at much higher risk for receiving opioids. And patients who go into outpatient settings are less likely, but more likely to receive some of those other interventions like imaging and injections, right? So the guidelines really are in support of initial conservative care without using any of those interventions, at least for the first 6 weeks, and to proceed cautiously if necessary, through proper referral and evaluation to consider those interventions, because there's a qualifier on the definition of low value, which is why we use two different definitions, right? So it's not low value in every case; it's very circumstantial. So it has to be customized.
Thanks for that, Brian. Ewan, I feel like this is sort of a nice transition from thinking about low back pain and opioids, prescriptions given for low back pain, and thinking about your work. Some of the questions here were interesting. So since the survey responses are fairly recent, I think you highlighted a lot of these we know this from the data set 2018, 2017, 2018. How do you handle the possibility that the negative social determinants of health is a result of opioid use disorder rather than a risk factor? I think you might be muted, or that might be on my end. Double check there.
Can you hear me?
Yes, we can.
Okay. So we handled it carefully in like two ways. First, our study timeline is echoed at like the very first outpatient opioid prescription, and like the opioid use disorder only counts if it happens after that index date. So like the main outcome timing is very clear. And secondly, in the model, the survey-based social determinants of health variables are treated as baseline associated factors for like the risk stratification, not like as proof of like the cause. So I think we are carefully not to claim that every negative social determinants of health measures can be for opioid use disorder. So instead, we use them to improve the prediction, and we clearly like list timing of the survey data as a limitation. We also take it into consideration in the model.
Thank you. Ewan, another one for you there, and I think this leads into a couple of the follow-up questions that are sort of tangentially related to this, but could you give a little bit of detail on how you handled issues of sort of missing data or missing quantity or PRN dosing while you're measuring the MME?
So we measured it at two levels. So first level is we calculated the MME, which we removed all the prescriptions, if it's like missing the duration, missing like the ingredients, or like missing the quantity. So when calculating the MME, we kind of like standardize the dose intake of opioids. And later for the social determinants of health factors, if like the survey answer questions, it has missing value more than, let's say, 40%, we will just remove that questions. Since at first we went through like more than 70 of the social determinants of health questions, but later we kept only 30.
Great. This is sort of an open question for all of you. We've got about 5 minutes left, and I thought this was an interesting one. On some level, the answer feels probably easy for all of you, but how could survey data, specifically the social determinants of health data, be improved in the data set? And I'll sort of add with that, would your research benefit from improved or expanded survey data in addition to the EHR data? So it's sort of two parts. Feel free to chime in and answer those from, we can sort of go round robin here, and maybe I can start with Brian and think about would better survey data, how could we improve the SDOH survey data, and would that affect your research?
Yeah, that's a great question, and not just related to the social determinants survey data, but overall, it would be very useful for someone who does research like I do to have follow-up survey, right? So we have survey data at a certain point, and like you had mentioned, we have to account for the timing between when that survey was completed and when the index visit for some outcome or for some condition that we're looking at. Sometimes those two things are very far apart, so it's hard to correlate a survey answer from, let's say, 2 years ago to an opioid use disorder diagnosis today. So follow-up survey data would be, I think, really, really helpful for researchers to track these values over time.
You and I saw your head nodding along with that, sort of the idea of longitudinal data to sort of reaffirm. That seems like the right thing. Eric, are you in any thoughts on that one, on the availability of data?
Yeah, I think like the EHR is very strong for prescriptions, diagnosis, and timing, but it like does not fully capture social context. So better and more complete survey data at all of us would help us like measure things like income, trust, education, even like family mental health, like family history, and also like the substance use history and other like social factors more directly. So yeah, I think it's very helpful.
Yeah, life never stays the same, right? Everything changes all the time. With that, I should know for our audience that later this year, we'll be launching the All of Us reassessment. So it's an opportunity to start collecting that longitudinal data, which should really enrich the data set. Eric, did you have any thoughts on that, on the availability of data and the quality of that?
Well, I definitely agree with both of the others. And also I want to add that there's so many missing data there, which like I taught in my presentation that there's a 91% of insurance type missing. And it actually causes like a lot in the like analyzing the data sets. So it will be like, I don't know if it's possible, but it will be better if we can like actually like check those like missingnesses and like put those values in. And yeah.
For sure. Well, we've got about 1 minute left. There are a lot of really good questions. Like there's 2 or 3 that we didn't quite get to, which I apologize for our attendees. Hopefully we'll be able to address those at some point in some way. I've got it as 2:59, so I'm going to take a moment here to say thank you to our panelists for sharing their work and demonstrating the potential uses and the actual uses of the data set and the information that our participants have shared with us to advance science. Thank you for joining us today, to our speakers and to our attendees. Up next, there are 6 workshops to choose from on the agenda. So all of the workshops are limited to the first 100 attendees. So it's sort of a like click in there real quick, or you might not find a virtual seat. So be sure to grab a spot. Voices of All of Us, though, is one of the sessions that is running concurrently, and that is not limited. So if you find you're not quick on the draw with clicking into the next session, you can always head there and there'll be room for you. So I will take the prerogative here and end us maybe about 30 seconds early, but say thank you to our speakers again. Thank you to all of us participants whose data made this possible. And thank you to all of you for joining.
Thank you so much.
Thank you.